Okay. So last time we discussed that whenever we have a patient whom we want to work up for squint, first thing we do is we refract them, refract under cycloplegia, and it has been started. Yes, it's. So we discussed that whenever we have a patient of squint, the first thing we want to do is we want to refract them into cycloplegia, perform retinoscopy, and check for their visual acuity. And we want to prescribe them glasses. Glasses are very important, even if squint is not accommodative. It helps a lot. It is indicated for the treatment of both accommodative and non-accommodative esotopia. So glasses are very important. So afterwards, where we left off, we said that at our initial checkup, initial visit, we will refract glasses. All right, that's done. After a while, in the next visit, we will assess compliance, if they use of glasses or not. We will assess the degree of squint, kitna squint hai, and then we'll reassess vision. So the questions which I left you last time were, what will we do if the patient is not compliant? Uska हमें जवाब मिल गया था. They will prescribe acetylcholinesterase inhibitors, atrophonium, etc., which cause accommodation without without neural impulses. So एक question का हमें answer मिल गया था. The second question was, how do we assess the degree of squint? There are two investigations which we use to assess the degree of squint. What are those investigations? That is my question. I told you last time that we will be discussing on this, और फिर उसके बाद हम आगे चलेंगे. There are two important investigations which we use in assessing the degree of squint. एक तो Hirschberg's test है. Hirschberg's में पहले से था. उसके बाद दो और है. Hirschberg's test is basically a very crude method. आपको अंदाजा हो जाता है रिफ्लेक्स से कि कहाँ हमने आई किस तरफ deviated है. But it's crude. Crude का मतलब it's not that accurate, or there are better ways and easier, and they're relatively easier to perform. आपको लंबी चौड़े मेहनत नहीं करनी पड़ती. First is Hirschberg's test. That's correct. What are the other two which we can do to assess the degree of squint? So prisms. Prism बिल्कुल, but prism से क्या आते हैं? The test has a name. Synaptophore. Now, synaptophore is used to assess binocular vision, right? It's used to assess binocular vision, and it's used to treat or further binocular vision. Uski improvement aata hai, to develop fusion, to develop stereopsis. That is what synaptophores are used for. They don't exactly tell us the degree of deviation. Fatma is right with prisms. However, you have to give a name of the test or the examination. Prism use करेंगे बिल्कुल. Prism उसमें use होता है test में, but what is that test? That is my question.
Prism bar test?
Prism bar test, yes. So the first test which we would like to perform is the prism bar test. Okay. So we will do a prism bar test. I will write that down. Achha. So prism bar test, that is correct. Prism bar test. There is one more test. It's usually done when patients, prism bar test cannot be performed on patients, or if there is no vision in the deviating eye. Okay. The prism bar test is also called the prism bar cover test because we cover and perform the cover and cover test in the prism of prism. And the last, the other test we perform is a Krimsky's corneal reflex test. Okay. I want you to both इसके बारे में आप थोड़ा सा पढ़ लेना. Basically, what we do is we assess the degree of deviation. I have a video of Krimsky's corneal reflex. Let's see that. I don't have a video, a short video of prism bar cover test, but I do have so I'll send that in the group later on. So this is Krimsky's prism bar test. These are different prism bars which are being used on this patient. Let's see what is happening in this video. So before I start, okay, there's a problem with the left eye of this patient. Okay, the left eye is deviated. And from the look of it, अगर मैं relatively compare करूँ तो I'd say that the left eye is deviated outwards क्योंकि दोनों के corneal reflex ऊपर है, but left eye का corneal reflex थोड़ा सा अंदर है. So it means that the eye is deviated outwards. That is what seems to me at the moment. So in Krimsky's corneal reflex, a prism bar is used to cover the fixating eye is covered using the prism bar test, and then movement is looked at in the other eye. Okay, so let's take a look back. Fixating eye is being covered by different prisms. ये पूरी bar है. This is a weak prism. फिर ऊपर stronger prism है, उससे ऊपर ज़्यादा strong है. So this whole bar, it has different prisms of varying strengths. So this is the weakest, then this is stronger, then the above one is stronger. So the fixating eye is being covered, and we want to look at the other deviating eye. Okay, let's look at the deviating eye. Can you see the deviating eye moving inwards? The deviating eye is moving inward, and it now almost appears central. Okay, so relatively more powerful prisms are being used. Okay, so at 25 diopters strength of the prism, and the prism he's using is 25 diopters, the left eye, it appears straight. However, he still continues forward to see that if that relationship is maintained. अब उसने एक और prism आगे किया तो it moved inwards again. Overcompensation हो गई. 30 diopter prism is too strong. The eye, it moves inwards. So after then he goes back again to 25, I think. No. So this is Krimsky's corneal reflex.
इसका principle क्या है?
Principle ये है कि prisms. The principle is that prisms are used. Prisms they deviate light. Okay. So let me just minimize this. I have an image. चलो मैं आपको थोड़ी देर तक दिखाता हूँ. बल्कि अभी थोड़ा सा आपको concept समझा. So prisms they deviate light. ठीक है, थोड़ा सा फिजिक्स में आपको पता है कि प्रिज्म जो आता है, प्रिज्म के अंदर से जब भी लाइट पास करती है, प्रिज्म इज ट्रायंगुलर, इट हैज अ बेस, इट हैज एन एपेक्स. ठीक है, इस तरह की शेप होती है प्रिज्म की. तो व्हेनेवर लाइट एंटर्स द प्रिज्म, इट इज बेंट टुवर्ड्स द एपेक्स. उसकी वजह से लाइट का पाथवे चेंज हो जाता है. तो व्हाट वी आर डूइंग इज वी आर चेंजिंग, क्योंकि दोनों आइज का रिलेशनशिप तो एक जैसा रहना है. हमने दिस इज अ कॉमेटेंट स्क्विंट. What we are trying to do basically, we're tricking the right eye. Okay, so that the brain thinks that all right, the right eye is moving. हालांकि right eye move नहीं हो रही, prism की वजह से सिर्फ light का pathway हमने change कर दिया. तो the brain is being tricked, और brain को लग रहा है कि vision right side पे है, तो it's moving, the right eye is moving rightwards, और left eye is moving inwards. हालांकि motion हो नहीं रहा.
ठीक है.
थोड़ा सा it's a difficult concept to grasp. Here it is. So this is what happens, right?
सही.
This is a normal eye, and this is a left eye. The point O, F is phobia, जो normally देखना चाहिए था. However, when we introduce a prism with the apex outwards, the light rays they deviate away from the prism towards the base. तो जब हम नॉर्मल आंख के सामने प्रिज्म डाल देते हैं, ठीक है, दिस इज द नॉर्मल, इफ नॉर्मल पाथवे ये था, तो हम प्रिज्म डाल देते हैं, तो लाइट रेज दे बेंड, देयर पाथवे इज चेंज्ड. सो इवन दो द ऑब्जेक्ट इज स्ट्रेट अहेड, लाइट द आईज दे हैव टू मूव आउटवर्ड्स टू परसीव दिस ऑब्जेक्ट, क्योंकि उसके अंदर से बेंड ऐसे हो रही है. This is not exactly the condition of the above test. However, it demonstrates the effect of prisms. How prisms they can change the pathway of the light. इसी प्रिंसिपल को इस्तेमाल करते हुए he has tricked the eye that the object is somewhere else, even though the object is right there. Again, the thing which he's focusing on. So I will hit this topic again in 4 years. थोड़ा सा इसको वैसे explain करूँ, but you have to read it on your own. Prisms मैं जितना भी explain करूँ, I think I will always be lacking, क्योंकि थोड़ा सा आपको इसके बारे में डिटेल में read करना पड़ेगा. However, the concept is this. This is the concept. इसकी application के बारे में आप थोड़ा सा brainstorm करेंगे तो it will be clear. At prisms, they deviate light towards their base. By introducing a prism in front of a normal eye, we can trick the eye to move and look at the same object, even though the object does not move. Right? आंख को लग रहा है कि object हालांकि इधर है. ठीक है? This eye is thinking that the object is here, even though the object is here. In reality, it's because the light is being bent. This was Krimsky's corneal reflex. It's one of the ways which we can assess the deviation of squint. The degree of squint or the degree of deviation. It is very important that we do that, because in the end the decision is surgery performed करनी है नहीं करनी and all that, it depends upon the degrees of squint. Secondly, अगर squint कम हो गया है from our initial visit, we will know that our treatment is working. That is why these tests are not only performed on the second time, they're also performed on the first time. First initial management, initial evaluation, you perform these tests. And these tests are very important. Esotopia में आपने इन tests का नाम याद रखना है. Abnormal eye इसलिए रखते Krimsky performed तब होता है when there is decreased vision or no vision in the abnormal eye. तो इनकी जो deviating eye थी, इसकी indication है कि deviating eye जो है, which in this case, इसमें vision ना हो. तो इसमें अगर vision नहीं है, और जिस तरह हमने पूरा algorithm बनाया था last time, if you remember, we discussed that the deviated eye cannot move. So these are the different possibilities. कुछ भी हो सकता है ना इनमें से. So if a deviating eye is not able to move, और वो वैसे fixation नहीं ले रही, तो वो prism के अंदर भी fixation नहीं ले सकती. If that eye, if the deviating eye is abnormal and it cannot fix normally on the object, क्योंकि हमने जब cover test में बात की थी, if we cover the eye and तो दूसरी eye fixation के लिए move करती है, लेकिन नहीं करेगी तो चार conditions हमने discuss कर ली. Now, if the eye cannot move, so how do you think it can take a fixation under a prism if it is not able to take a fixation normally? In those cases, अगर वो मसला नहीं है, I move करती है, तो our first thing is a prism bar test, prism bar cover test. I'll send you a video, group में इसको देख लेना एक बार. We'll discuss this tomorrow again. Otherwise, we will use a Krimsky's corneal reflex test, क्योंकि इसमें हमें patient की fixation पे depend नहीं करता, हम corneal reflex को देख के अंदाजा लगा लेते हैं. Alright, corneal reflex center हो रहे, तो eye is almost center. Okay? That is why this is used. So, we reassess the degree of squint. We classes की compliance हम check कर लेते हैं. That is good. Now the next thing we want to assess is whether that person has foveal suppression or not. In other words, we want to assess whether the patient has amblyopia or not. So there are two possibilities in this case. जाहिर बात है, या उसको amblyopia होगा या amblyopia नहीं होगा. So the first thing, amblyopia is present. तब हम क्या करेंगे? Second thing, the second possibility, right? दूसरी possibility है ये ना कि there is no amblyopia absent. तब हम क्या करेंगे? So what should we do when amblyopia is present or when amblyopia is absent?
Occlusion या patching कर देंगे अगर amblyopia होगा normal eye की, ताकि जो जिसकी foveal suppression हुई भी और lazy eye है वो take over कर ले.
Foveal suppression है, lazy eye है, देख रहता है. ठीक है, that's good. So whenever amblyopia is present, we have to treat that amblyopia. How can we treat the amblyopia? Okay, one thing you said, that's good. It's patching. Patching some amblyopia treat कर देते हैं. So that is one treatment modality. There's another treatment modality. वो क्या है? Repeat that. दो लोग एक साथ बोले, मुझे दोनों की समझ नहीं आई.
Pharmacological penalization.
Penalization, right? So the treatment of amblyopia is two P's. The first is patching. इसको हमने अपने उन 4 O's में occlusion के तौर पे याद किया था. And the second is pharmacological penalization, or in short PP. I am abbreviating it. So what are the principles behind this treatment? The Principle is that we occlude the normal eye for a given period of time. The ratio is x ratio 1, where x is the age of the patient, child. Yeah, 1 ratio x up there. For example, in our case, the child is 4 years old. What will we do for amblyopia? It's 1 ratio 4, 1 hour with a normal eye. मतलब normal eye से हम 1 घंटे के लिए vision allow करेंगे. Then we will patch the normal eye for 4 hours, forcing the child to use his abnormal eye or the deviating eye. So forcing him to pick up fixation with that abnormal eye. Okay? So that is important. That is important that we do that. However, patching sometimes does not fit. And in that case, we use pharmacological penalization. Now the question is, why do we have to resort to pharmacological penalization? And my second question is, how do we do it? पैचिंग के बाद हमें दूसरी चीज तक क्यों आना पड़ रहा है, और अगर आना पड़ रहा है तो हम कैसे करेंगे? So the answer of my first question is, put yourself in the position of this child. You don't have good vision in one eye, you sacrifice vision in one eye, and only one eye is normal. Now the doctor, now your parents, they want to close that good eye for 4 hours, forcing you to use this left eye in which you have no vision. Okay? Children, young children, 4 years old, he's a young child. Children, they don't have senses उनकी इतनी develop नहीं हुई होती. They rely heavily upon visual stimuli and auditory clues. So you're basically depriving him of one of his most important senses. Will a child take lightly to that? No, they will remove the patch. जब भी मौका मिलेगा रोएंगे धोएंगे patch remove करेंगे. ठीक है? The compliance is very bad because children, they don't understand why आप उनकी अच्छी वाली आंखों के साथ क्यों मस्ती कर रहे हैं. ठीक है? So it's very traumatic for both the child and the parent as well. But it has to be done in order to save. So if patching is not successful, the other alternative is pharmacological penalization. We make vision with this eye impossible. How do we do that? By applying or by topically inserting cycloplegics. Cycloplegics, they include atropine, they include hematropine, they include cyclopentolate. They include tropicamide. क्या करते हैं ये? They basically cause pupillary dilation. And second thing is they accommodation को खत्म कर देते हैं. They abolish accommodation. ठीक है? They block accommodation. So what happens? The child is unable to see. The pupillary dilation हो जाती है तो there is such immense photo sensitivity. आंख फोटोफोबिया आंख इस तरह होता है जिस तरह आप अंधेरे कमरे में सो रहे हो और अचानक पूरे कमरे की लाइट्स ऑन कर दें. जिस तरह का दर्द उस एक लम्हे के लिए होता है ना, that discomfort that you feel for 1, 2, 3 or 4 seconds, the child feels that discomfort for as long as the action of the drug persists. However, he is unable to do anything with that, anything to that except cry. So it is one of the alternatives that is used. So treatment of amblyopia, it consists of 2 things: patching and pharmacological penalization. Now you know why we do these things and how we do these things. ठीक है, amblyopia. If amblyopia is absent, तो ये थोड़ा सा मुश्किल हो जाएगा. मैं आपको बता देता हूँ. Sometimes what happens is that the esotopia is intermittent. Intermittent basically means कि esotopia fully develop नहीं हुआ, लेकिन ये ईजोफोरिया से आगे निकल गया. फॉर एग्जाम्पल, सारा दिन काम करते हुए कोई मसला नहीं होता, शाम को थोड़ी आंखों में थकावट होती है, रात को आंखें पक्की पक्की टेढ़ी हो जाती है और ज़्यादा टेढ़ी रहती हैं लेकिन प्रोलॉन्ग रेस्ट के साथ ठीक हो जाती हैं. दैट ईजोट्रोपिया इज इंटरमिटेंट. वी हैव टू रूल आउट वेदर द ईजोट्रोपिया इज इंटरमिटेंट और नॉट. इसकी ट्रीटमेंट अपनी है, अलग है. वी विल डिस्कस दिस विद फोरियाज के साथ हम इसकी मैनेजमेंट डिस्कस करेंगे. Other thing is that there is no amblyopia, visual suppression नहीं है, but this child he has a constant esotropia. Yeah, this one we have discussed here. Okay, it's constant. And in constant esotropia, constant esotropia, amblyopia is absent. The patient has no amblyopia, he has good vision. Now the important thing we have to see. अभी हमें क्या assess करना चाहिए आपके लिहाज से? This is my question. So we've assessed amblyopia, and in both cases, if amblyopia is absent, we've seen कि alright amblyopia नहीं है, तो is our esotropia intermittent? थोड़ी सी हिस्ट्री हमने बेहतर ले ली. नहीं, it's constant esotropia. And if amblyopia is present, we've treated amblyopia. What should we do now? What should we assess now? Think of the 4 O's which we discussed last time. Okay, the 2 of them we've applied. We've applied occlusion, which was the treatment of amblyopia. We've applied optical correction. Only 2 O's are remaining now. Which one should we do
surgery,
now?
Ocular surgery.
Surgery, number 4 pe humne discussed. Orthoptics. So what was the base principle of orthoptics?
To develop the binocular vision.
ठीक है, orthoptics, binocular vision. Binocular vision के कितने grades होते हैं?
Or fusion. 3 grades होते हैं.
3 grades होते हैं. So what is the first grade?
Macular मतलब कि macular के ऊपर focus हो रही light, and दूसरा होता है fusion, and तीसरा जो depth perception.
Sidereosis, right? That is good. That's excellent. So we want to know, does this patient have binocular vision grade 1? Grade 1 vision. Grade 1 binocular vision. Binocular vision. So we want to know whether this patient have grade 1 binocular vision. In other terms, if there is binocular vision, grade 1, यानी कि इसका दूसरा नाम क्या था? Normal retinal correspondence. ठीक है? That both the maculas are being used to perceive or see the image or the object. Normal retinal correspondence है या नहीं है? That is the first grade. So this is the first grade. There are 2 answers to this question. What is the first answer? What is the second answer? It's a closed-ended question. The answer is either yes.
Yes or no.
The answer is either no. Okay, it's pretty simple. No को हम discuss कर लेते हैं. So, does this patient have grade 1 binocular vision? Normal correspondence. The question is yes. If yes, then what should we assess? अब हमें क्या assess करना चाहिए?
Fusion.
Fusion. We have to assess whether this patient does this patient have grade 2? Or does this grade 2 हमने देख लिया कि चलो grade 1 है, तो grade 2 का दूसरा नाम क्या था? Fusion. So we have to assess whether this person have fusion. तो इस पे हम अभी discuss कर लेते हैं. But what if the person does not have normal retinal correspondence? इसका मतलब ये है कि this patient has eccentric fixation. This patient has abnormal retinal correspondence. This patient has fovealization of another part of the retina. In this case, what will you do next? Now that you know that, all right, this patient has eccentric fixation, abnormal retinal correspondence, this fovealization of the retina. What will you do now?
सर्जरी करेंगे ना, क्योंकि मोबिलाइजेशन ठीक करने के लिए.
मोबिलाइजेशन ठीक करने के लिए व्हाट आर यू सेइंग कि हम क्या करेंगे? सर्जरी करेंगे. बट हमने तो डिस्कस किया था कि अब रेटिना का नॉर्मल चेंज हो गया. रेटिना हैज अ न्यू नॉर्मल नाउ. सो इफ वी ट्राई टू चेंज दिस न्यू नॉर्मल विदाउट चेंजिंग इट,
रिकरेंस हो जाएगी.
रिकरेंस हो जाएगी ना. So what we want to change this eccentric fixation. Amblyopia was simply suppression. ठीक है, एम्ब्लायोपिया सप्रेशन हो गई, उसके बाद देयर इज adaptation. That adaptation is in the form of eccentric fixation, ARC fovalization, etc. All right. So what we will do is we will try to stimulate the retina of the fovea of this patient. Even though he has abnormal retinal correspondence, हम क्या करेंगे? We want to stimulate his fovea. हम सोए हुए फोबिया को दोबारा जगाना चाहते हैं. So we will
pinhole कोई हो सकता है?
Pinhole को, ठीक है, you're right in a sense कि pinhole only gives light rays to the retina. That is correct. Okay, that's good concept on your part. Basically, what we do is we try to stimulate fovea in an isolated manner, not using the pinhole, but in an isolated manner, so that the fovea, it tries to regain its function. This whole procedure of trying to stimulate the fovea with flashes of light, bright light, any of the sort, this is called pleoptics. Okay? This is a new word. We haven't discussed this, and we didn't discuss this in our 4 O's, okay, which we discussed over here. But it's a part of therapy. Pleoptics means that we're trying to rejuvenate the fovea. We're trying to regenerate it so that it picks up vision again. So after we've done pleoptics, there are 2 possibilities. Again, what are those 2 possibilities? Okay. Pleoptics work. The first is काम करेंगे कि नहीं? The first is pleoptics worked. And if pleoptics worked, that means that the patient now has normal retinal correspondence. और normal retinal correspondence का मतलब ये है कि we are now on the track of this. However, if the pleoptics do not work, then what we can do? If the pleoptics, there is no improvement, then either we will leave the case over here, because it is impossible to develop grade 1 vision. तो grade 1 नहीं होगा तो grade 2 कैसे होगा? And even if in this cases, if we perform surgery, we will only perform surgery for cosmetic reasons. So if pleoptics fail, then we'll do squint surgery, but only for cosmetic reasons. Cosmetic surgery. Acha. So does this patient have grade 2 fusion, grade 2 vision, binocular vision or fusion? Again, there are only 2 answers. Yes. And the second is no. What will we do in either case? That is my question. So अगर fusion नहीं है एक patient में, but he has grade 1 vision, he has normal retinal correspondence, he has grade 1 binocular vision, what can we do in this patient? Remember the 4 O's.
Orthoptics.
Orthoptics, ठीक है? We want to train binocular vision in this patient, so we will use orthoptics. Orthoptics का भी यही हाल है कि we will try orthoptics again and again and again until they work. ठीक है? They can either work or they cannot work. नहीं होगा हम करेंगे तो हमें पता है what we saw in optics, right? So orthoptics, now this patient develops grade 2 fusion, grade 2 binocular vision fusion. What will we do now? अब हम क्या करेंगे? What was the final O?
Ocular surgery.
Ocular surgery. ठीक है? Ocular surgery. Now is the time to plan for ocular surgery. Ocular surgery का ये है कि it sometimes depends on the degree of deviation. Degree of deviation हम एक तो treatment monitor के लिए भी कह रहे थे, उसके लिए भी काफी important थी, because it let us know the response of our treatment. The second is if the squint is enough to perform ocular surgery. So normally they say if ocular surgery is performed, Parson says this, ocular surgery is performed when the degree of squint is greater than 20 prism diopters, और इसको 10 degrees भी कहते हैं. Prism diopters और degrees का ना half relationship बन जाता है तकरीबन. So if the deviation is greater than this. For example, in the video, we saw that the prism, the deviation was around 25 diopters. So in this case, if we follow this algorithm, if we follow this flowchart, then yes, surgery is indicated. So again, nahi hai, isse kam hai, it means that our treatment is working and we should follow up with our treatment. कौन सी treatment हम कह रहे थे? We should follow up again with orthoptics, try to develop binocular vision. We should patching तो हमने कर ली थी. The starting treatment classes से आप कंटिन्यू रखें, orthoptics आप कंटिन्यू रखें, स्क्विंट कम होता जाएगा. और फिर उससे आके अगर फिर फाइनली सर्जरी स्क्विंट की जरूरत पड़ती सर्जरी की जरूरत पड़ती है for that squint, then it's again a clinical decision. So this was the last step in our flowchart in our algorithm. Let us have a broad overview. So a patient, if presents to you with squint, in our case, this chart has esotopia. The first thing we will do is we will perform a baseline evaluation, right? We will perform refraction under cyclopedia. Visual acuity का हमें अंदाजा हो जाएगा. We will perform extraocular movements. Then we will perform the Hirschberg's test and the cover test to assess what type of squint it is. ठीक है, वो ऊपर उसका algorithm है. Then we will check out deviation, degree of deviation, using a prism bar cover test or Krimsky's corner reflex. After that, depending upon the degree of visual acuity and the responses of the eye, we will assess whether the patient has amblyopia or not. If amblyopia is present, we will treat amblyopia by occlusion, which can either be amblyopia or the second O. We can do patching or we can do pharmacological penalization. If amblyopia isn't present, then we have to assess whether this patient has good binocular vision, because the ultimate goal of squint therapy is to make sure that the patient has binocular vision. एक आंख से तो देख ही रहा है. We want the patient to have binocular vision. So the first grade of binocular vision is normal retinal correspondence. We want to see if that present or if the correspondence is abnormal. If it's abnormal, we will try optics. We will try to simulate the fovea, ताकि normal retinal correspondence की तरह develop किया जाए. But it has a chance of failing. If it fails, then we will go for cosmetic surgery. If the optics works and the patient has good normal retinal correspondence, then we will assess whether this patient has grade 2 binocular fusion. If fusion nahi hai, we do orthoptics. Orthoptics is exercises. These are exercises, not movement of the eyes. They are physical muscular exercises. These are regimens which help us develop binocular vision, stereopsis and fusion. These are done using a synaptophore. So if orthoptics works, then we have to finally assess whether this patient is a candidate for surgery or not. After assessing that, we will perform a surgery, or we will just continue with our normal treatment if everything is going according to plan and everything is going good. So this was a brief to me, thoda sa lamba hai, but it basically highlights the important concepts, and it includes all of these four key principles of management. Again, in examination, you won't have time to go over this discussion. Viva bhi examiner aapse kabhi expect nahi karega. They only want you to tell these things: optical correction, occlusion, orthoptics, ocular surgery. But you will only remember these.
भाई एक ही पेज पे ये सारा आ सकता है, इसका स्क्रीनशॉट?
ये मैं आपको पार्सन्स के इसके पेजेस भेज दूंगा. इसमें थोड़ा सा एक दो स्टेप्स डिफरेंट है, तो आप उसी को फॉलो कीजिएगा, इसको ना करना. ये तो आपकी अंडरस्टैंडिंग के लिए मैंने थोड़ा सा साथ साथ बनाया. मैं आपको उसके पार्सन्स के अंदर से मैंने पार्सन से ही बस पेज कॉपी पेस्ट करने की बजाय मैंने कहा कि ड्रॉ कर लूँ, थोड़ी बेटर. तो आई विल सेंड स्क्रीनशॉट्स ऑफ बोथ दीज मैनेजमेंट प्लान्स इन द ग्रुप. मैं आगे भेज दूंगा. So after we resume, I'm going to end this now. After I come back, we want to discuss the different types of surgery for squint, and then we will discuss this algorithm, but this time for latent squints. Okay? So I'll be back in a minute.